I want to welcome everyone back to the podcast. And as always, I want to thank you all for listening. In today's podcast, I'm going to be interviewing Stephen Wright, MD, who is a residency trained family physician with 38 years of experience. Although no longer providing direct care to patients, he remains active in addiction medicine, board certified, now for 33 years, and pain management for 17 years. He has a particular interest in benzodiazepines, having developed, run, and presented at the International Benzodiazepine Symposium in 2017 in Bend, Oregon. He is the medical consultant for the Alliance for Benzodiazepine Best Practices and is involved in a variety of related projects. He presents across the country, virtually now, and is editor and co-author of 2 chapters of a book on benzodiazepines, now available, called The Benzodiazepine Crisis, The Ramifications of an Overused Drug Class. Please stay tuned after the podcast for our post-show talk. I am so pleased to welcome Dr. Stephen Wright to the podcast because not only is it important for those suffering from benzo withdrawal to hear from a medical professional, but also to help their family members understand that what we go through is real. Welcome, Steve.
Thank you so much, Geraldine. It's a real honor and a pleasure to be here to share with you my experience as a medical provider, mistakes that I've made, missteps, and what we're doing to improve prescribing and deprescribing of benzodiazepines that is so important for so many individuals.
Right, very important. Now, you and I had talked last week about a list of questions that I had prepared that I wanted to go over. And after you sent me the chapters from the book that's coming out, I want to skip a lot of questions and I want to concentrate on some major issues, if that's okay.
That's perfectly fine.
All right. So, you were the medical director of the first International Benzodiazepine Symposium that Marjorie Common put together, which was held in Bend, Oregon from September 15th to 17th in 2017. Can you tell us a little bit about the symposium with all the work that you did and with all the work that you have been doing these last few years? Do you feel the medical field is catching on yet?
The short answer to the last question is no. We have a long ways to go, and I was included in that. I included in that group over such a long period of time. I grew up in family medicine, graduated from a residency program in 1982, started doing addiction medicine 33 years ago and medical pain management about 17 years ago. And of course, along the way, much contact with individuals and the issues surrounding mental health issues, as well as the medications we're using, and of course, included in all that is benzodiazepines. I had thought that benzodiazepines were old story. We know everything. The things that I heard from my mentors were accurate in the way to do this, that problems were somewhat unusual and not expected on a generalized basis. And I didn't know about the extent and severity of the problems until that particular conference. So Marjorie had asked me to chair this conference, put together things. And the thing that was really impressive to me and actually overwhelmed me was the story. The thing that impressed me in particular were the stories of the lived experience of individuals who had struggled with benzodiazepines. That affected all of us. That affected the presenters at the program in such a way that we started to think about things differently. And at that particular conference, Bernie Silvernail and his wife came and wanted to put together, and we did put together, the Alliance for Benzodiazepine Best Practices, which focuses on the concerns of the prescribers and how to implement best practices, whereas I and many others have not used those best practices over many, many years, and as a result, ended up inadvertently, in large part, harming individuals with the benzodiazepines.
But all with good intention when you were originally prescribing until you learned and you heard these lived stories,
Yeah,
correct?
I mean,
Yeah.
we truly thought we were doing the right thing for the majority of individuals, and to be sure, for a number of individuals, harm hadn't taken place, but there was still a significant number of individuals that were harmed.
Right.
We have to be honest about that.
Right. So I had just recently listened to Bernie and his wife Carrie's, Bernie Silvernail and Carrie Silvernail's podcast that Jocelyn did about benzoreform.org and what they're doing. And I knew about the website, but I didn't know who it was geared towards until you and I spoke. So can you tell us a little bit about that? Because I find that website to be one of the best places people can start sending their doctors.
Certainly. So benzoreform.org, actually, it's the Alliance for Benzodiazepine Best Practices, which can be Googled. And by the way, the website is currently being revised, should be up in about a week.
Hmm.
The focus there is on the prescribers. There are a lot of internet sites that pay attention particularly to the affected individuals and their families, and that's very, very important. What we wanted to do was to assist prescribers to move towards best practices, and so that is our focus, although, of course, we attend to the concerns of patients as well.
Correct. I am so thrilled about this site, and anybody listening, this is the site to start sending your doctors to, because if they're not going to listen to us, they're learning. Can you tell us some of the things that are going to be? I know the site's being redone. What's going to be on the site?
Certainly. We have sections in there for prescribers in particular that includes a library of literature where prescribers can look at the literature themselves. We list out best practices in such a way that individuals can understand in a short version as to what those best practices are. I mean, there's an enormous amount of literature to go through. We also have a section on for patients as well, patients and affected families, where individuals can go in, look around, gain information, as well as tools for those individuals that so that they can take those tools to the doctors or other prescribers and assist them to understand the scope of the problems that many individuals are facing.
Well, yeah, that's going to be a very, very good website. And is there going to be anything where doctors, let's say, would get credit for learning on that website, so that might give them some incentive to go there?
We have links to other places where that CME credit, continuing medical education credit, can be acquired, but currently not directly through the website itself.
Okay, okay. So now I want to get into the book that you're one of the co-authors of, The Benzodiazepine Crisis, The Downside of an Overused Drug Class. And we just want to mention that on Amazon, if anybody goes to look, right now it currently says that it's the Benzodiazepine Crisis, The Ramifications of an Overused Drug Class. And I have to say, when I read chapter 8, that you wrote, I wish my doctor had this information. It had, I have to say, everything that I would have wanted my doctor to know, that also made me as a patient understand also what was happening to me. So do you want to talk a little bit about, what you contributed to the book?
Well, I appreciate that, Geraldine. The book, I was one of the three editors for the book, really looks at the scope of benzodiazepines in a variety of ways. We look at the neurophysiology, which not only includes the neurophysiology that encompasses the GABA receptor, but also the newly recognized peripheral benzodiazepine receptors and how that might affect individuals as well. We look at the scope of addiction, which actually is quite rare in individuals struggling with benzodiazepines, but nonetheless, some of that can occur. And we look at the adverse outcomes as well as what are the legitimate uses of benzodiazepines, which in our formulation, and we believe that it's valid to date based on the literature that's out there, that 2 to 4 weeks really is the time limit for benzodiazepines in large part. Now, I'll never say never in medicine because there's always exceptions to the rules,
Mhm.
but I think in large part that 2 to 4 week limitation, and that's probably the best way to prevent downsides to these agents. And those downsides are enormous for a lot of individuals. Problems with thinking, problems with decision making, problems with coordination. Even cancer has been related to benzodiazepines to a certain degree, although that's a newly explored area. And then, of course, physiologic dependence and the resulting consequences from all of that.
Right. Would you mind if I read just a couple of lines? Like there were so many things that I loved, but I pulled out just a few lines. Can I read just a few of those if you're okay with that so that
Oh, sure.
people understand that you really get it? So one of the lines was preparation for de-prescribing is critical. Frequently, insufficient or no informed consent has been provided. Therefore, education about risks, benefit, and alternatives need to be provided. And that goes on more and more. Another one was patients, after all, are the experts when it comes to their own experience, which again, you got it. We're trying to say what's wrong with us and nobody's listening. And another one says, again, primarily patient direct approach involving shared decision making is most likely to result in favorable outcomes. Um, Another one here is medicine as practiced today sits within a culture that encourages adding, not subtracting medications. And the last one I'll read is patient education and informed consent is not only effective, they are ethical and legal obligations. I mean, everything, I loved everything you wrote.
Well, I appreciate that. Certainly, it's a lot to unpack. Perhaps you want to choose something there that we can kind of explore.
Okay. Well, first of all, you get it that the patient has knowledge about their own health. They're trying to tell their doctors. I'll use myself for example. For the whole 10 years I saw my doctor, I said to her, I believe these drugs are making me sick. And she discounted it every single time, including when I came off and brought her information from England. I finally had gotten information from another country, and she handed it back to me and said that I was not, well, she used the word addicted to Ativan, that it was still, and she constantly wrote in the notes, it was harmless and non-addictive. I mean, that's why you get it.
Well, yeah, and that's a perfect example of the kind of things that happen far too frequently. Now, it is true that addiction is not part of the issue in the vast majority of individuals. It is, however, a possibility among a very few individuals. Individuals that use benzodiazepines may use them non-medically, in other words, for purposes other than for which they were prescribed. That typically is in individuals that already have a substance use disorder of another type. So, for example, benzodiazepines can amplify the effects of alcohol and opioids to get a bigger kick, and they can soften the withdrawal of other agents as well. But that's not typically what we're talking about
Right.
among individuals with benzodiazepine related problems. This becomes very difficult and confusing for medical providers, and I certainly was one of those because we sit there trying to sort out and land on a diagnosis that really is valid. Sometimes we're right, sometimes we're wrong. Sometimes patients are right, sometimes they're wrong. But too often we have discredited patients along the way in terms of their lived experience. But let me give you an example in that regard.
Hmm.
An individual shows up with hypersensitivity to sound, taste, or touch in the context of benzodiazepine withdrawal. We're thinking, boy, that's unusual. Haven't heard about that before. And it's so peculiar that we think it's got to be something else. And so, on behalf of prescribers, there really is an honest question about what is the relationship to what's going on in a patient's life? So for example, discontinuing benzodiazepines to the symptoms involved. And if we have not heard about or heard much about, the relationship to hypersensitivity to sound, taste, or touch, we may not recognize that relationship and be seeking an alternative diagnosis. So it is, in fact, difficult for those of us in the prescribing community to be able to sort that out.
Right. Yeah, and I can see that. But now on the benzoreform.org site, all the symptoms of withdrawal are going to be on there so that a doctor can recognize it. So if somebody walks in and says, "Hey, I'm having all these and I'm trying to tell you, but here's a website," will all these symptoms, withdrawal symptoms, be on there?
Yes,
Okay.
as well, we're creating a section of what I'd call surprise symptoms, symptoms that most prescribers would not recognize as being related to benzodiazepine withdrawal, because there's a long, long list, and we in medicine are very familiar with long lists of potential side effects or side effects to withdrawal processes as well. Uh, but it's the surprise symptoms that make this carry us off to the possibility of an alternative diagnosis.
Right.
There is this diagnosis that's called somatic symptom disorder, and it comes out of a tradition of looking at certain things that patients may be experiencing or expressing as being psychosomatic.
Hmm.
That's a real pejorative kind of situation where you're kind of blaming the patient for doing something or having a symptom that is there. When you think about it, very severe pain is a somatic symptom, but we don't describe them as having somatic symptom disorder, a hypersensitivity state. So like in fibromyalgia, if I take a shower and it hurts to take a shower, we don't call it somatic symptom disorder, although the vast majority of individuals taking a shower doesn't hurt at all. But when we talk about hypersensitivity to sound, taste, or touch in the context of benzodiazepine withdrawal, we might say somatic symptom disorder, when in fact it really is a physical, chemical based entity that occurs in the context of benzodiazepine withdrawal and is valid and shouldn't be somewhat blaming of patients for that particular presentation.
Right. Yeah. And that there are a lot that, have pain. I had pain wherever I had a scar, let's say a little surgery here or something there. That's the only time pain I had. I didn't have like leg pain, like some of them talk about. And there was one woman in the groups years ago that she had this sensation of a meat hook up her rectum that was so bad and so painful for her. She went doctor to doctor. And then one day, 14 months later, gone. So the pain was real. She felt it. And that was all from withdrawal, a symptom she had.
Those are
So you
perfect
never know.
examples. Those are perfect examples of the kind of things that puzzle us. But now we need to draw attention to the prescribers that there is a relationship to the withdrawal process and those symptoms, and not to be endlessly seeking other alternative diagnoses or blaming the patients for, say, making it up.
Right. Well, the line in here that says medicine as practiced today sits within a culture that encourages adding, not subtracting medications. Heather Ashton used to say, with all the calls and emails that she used to get, that the United States and Canada had the most multi drugging. And that has been what's going on. You walk in with all these symptoms and you're coming out with another drug. So I'm hoping with the book coming out and your website, this will start coming down because truly you see some people on 2 benzos, 2 pain meds. It's crazy.
It is crazy, but that's the culture in which we all grew up.
Right.
And it really is. That's the so called received knowledge that you want to keep chasing things down. But oddly enough, what you're often chasing down with a new medication is chasing down the side effect of the previous one.
Right.
And you end up compounding one problem on top of the other. And then we sit with a long list of even 15 or 20 medications, wondering where is the source of the problem, and how do I start into all of this?
Right. And well, the other part in here about patient education and informed consent is not only effective, they are ethical and legal obligations. So one of the things we were going to talk about was, here in Massachusetts that we filed a bill. But here you're saying if there was that patient education informed consent, we wouldn't even have to be doing a bill to bring attention. And you would think in all the years that we've been filing that something would be done. But here in Massachusetts, they're still ignoring it. But that's okay for now. We'll just keep fighting it. But you covered everything. And that's what people want is that you are recognizing this is a problem and we should be informed first. Because I think plenty would walk out of an office and say, you know what? It's a temporary situation or for whatever they're being put on it for. And really, I had a list of 3 pages that people were prescribed benzos, and anxiety wasn't one of the main reasons these people in our group. They were put on for, I mean, side effects from drugs. It was a short term, like they had a sickness. I remember one said they had the flu too long, so the doctor prescribed a benzo. Weight gain, weight loss, side effect from another drug. These are all the reasons they were prescribed, and I'm just hoping this is going to stop.
Yeah, and I hope so too. I mean, it's just remarkable that that this is our go-to as medical providers. You know, what's the next medication to solve this particular symptom? And even if that particular symptom quiets down for a while, there's a lack of recognition that that quieting out period does not mean that long-term use of whatever medication, in this case benzodiazepines, is really going to work over the long period of time. And very often it does not.
Right. Right. So one of the things on the groups lately are people who are taking antibiotics and having setbacks. So you actually covered fluoroquinolones in here, said should be avoided, which Heather then later added to like a page at the front of the manual because, again, we see a lot of people coming into the groups because they had they were floxed and they are put on benzos, and so that's one of the ones to avoid. But we see people on other medication, other antibiotics having a problem. Has there been any research done on what the antibiotics are doing? I mean, myself, I had a reaction to it, the Z pack, and I was able to recover very quickly from it. I knew what to do, but there are others that they're panicking that they're not going to get well, but the body heals. That's the good part.
Yeah, and we hope it heals for the for everybody. So the short answer is almost no. There is some literature on the fluoroquinolones, but the other antibiotics, to my knowledge, have not been explored. It, and that certainly is outrageous in the sense that here is something that becomes evident to a number of individuals and is yet to be explored by researchers in that regard. But very clearly, fluoroquinolones, possibly not with everybody, but
Right.
certainly enough that it should be avoided. Fluoroquinolones will block the GABA receptor and precipitate accelerated withdrawal in individuals that are affected.
Right. Okay. And again, I just say to people, we're all different. Some can take them, some can't. So they have to make their own decisions. One of the other things I want to talk about is the FDA black box warning that just came out on all benzodiazepines. So when we were talking about that, you said we don't know for sure what are they actually going to say. I mean, what do you know about that?
So the FDA just recently came out with the announcement that they're going to introduce a boxed warning on the class of benzodiazepines, and they referenced that that the content of that boxed warning was going to include concerns about abuse, addiction, non-medical use, and physiologic dependence. And now we don't know exactly what the wording is going to be, but what they did was they looked at their own data, what's called MedWatch data. This is where individuals, either patients or their prescribers, can inform the FDA about unusual or dramatic reactions that are significant enough to uh, quite adversely affect the lives of benzodiazepines. That MedWatch data, we took a brief look at it ourselves at the Alliance. The MedWatch data actually showed that there were more notifications in the class of benzodiazepines than there were with opioids until 2018. And so it's at a level of concern that should be very similar to that concern that we express in relation to the opioid crisis. We don't know what the content of that box warning is going to be, but we are very pleased that there is going to be an additional boxed warning for benzodiazepines in that regard.
Right. I mean, for me, when I saw it, it was like, a double-edged sword. It was like, okay, it's being recognized, but I feared that some doctors will start to cut people off too quickly, cut them off cold turkey. And that kind of leads to my next question. How can a good patient deal with a doctor who wants to taper them too fast or cut them off? How do you deal with them? From your point of view, is there a way to talk to them? Because some of them don't like to be told. well, hey, I've been on the internet looking at this, or here's this information. Any suggestions?
Yeah, this is a very difficult conversation, and I would suggest that individuals might go to our website at the Alliance to get some pamphlets as to how to talk to their prescriber about things like this. But this is my suggestion overall.
Okay.
First of all, there's a lot of fear in the part of prescribers that suddenly when they identify, oh, there is a big problem, now I have to quickly get out of it. Well, I think it's important to remind the prescribers that I'm here now. I haven't had an overdose or my breathing didn't stop. And so we don't necessarily have to rush into this. I am all in on uh, reducing the dose. I want to get out of this in a big way as
Hmm.
well. But I think we can pace this in such a way that the withdrawal process isn't as serious as the problems that I'm currently facing while I'm on the benzodiazepines as well. And my recommendation in terms of sorting out all the literature and the experience of individuals that have been doing this is that the first reduction should be 5% or less. And if an individual has a very easy time of doing that, you can increase the amount at that particular time. And so those discussions might take place with the medical provider. Say, hey, let's just take it real slow for that first step. And if it's easy peasy, we can increase it the next time. I'm all in on making those reductions as quickly as is reasonable. But I think providers have a tendency to move too quickly in that regard and try to conclude the tapering and discontinuation process in just a few weeks or a few months. Indeed, probably ought to be thought of in terms of 12 to 18 months or even longer for some individuals. But take a small step. If it works well, take a larger step. If it doesn't work well, give it more time at the lower dose and take a smaller step after that.
Right. And I like that you cover that in the book. You'll say it could take between 12 and 18 months, but for some it could take years to taper off because, that's symptom-based tapering. That's what we're all looking for. But while we were just talking, I just thought of something. Years ago, this orthopedic doctor called me who was suffering coming off of Xanax, and he said that if you go to an addiction doctor, and again, I don't know if this is true, so hopefully you can help me with this. If you go to an addiction doctor, insurance will only cover so many weeks. So they're going to taper you very fast versus if you go to a regular doctor. Is that true? And is it based on somebody's insurance company? I have no idea.
Yeah, I'm not sure you can exactly characterize it in that way. I think that what's being referred to there is more likely if you go to an addiction doc and you're placed into a treatment center, you have only a certain amount of time. But typically, if you're in an outpatient practice with an addiction doc, you can go as long as is necessary and not have those kind of time constraints. It has to do primarily with inpatient detox, and the framing of it is that inpatient you can't be in there for 12 to 18 months. Nobody can
Right.
afford that,
Right.
and so it's unrealistic to do that. And so I don't recommend doing that. The second problem with detox centers is that it's all shaped around the concept that whatever you're in for, benzos or otherwise, is an addiction. And if you push back on that, you're in denial. But in fact, individuals on benzodiazepines hardly ever have addiction. They're just having a difficult struggle to get off the medication and not getting the assistance that they need to be able to do so. That's the source of the problem, not addiction.
Right, right. Because I actually had one of my benzo friends who's a nurse, unbeknownst to her, as she's taking what her doctor prescribed, and then he puts her into a rehab. She's not even sure why. He's like, you know what? I just want you to come off it now. And they treated her like such an addict there. She said it was terrible. She ended up having they wouldn't let her out, and she ended up having to escape. And then they even called her family members and said, "Don't talk to her, don't believe her, she's an addict." I mean, she was so traumatized by what they did to her, and she was clueless, just taking it as he prescribed. So we do have the horror stories out there, and I think that the way you put it in the book is, working with your doctor. It's like I said, when the book comes out, because you can pre-order it now. I think everybody will be so pleased that you have the heart of what we feel in that chapter.
But you make an excellent point. When you enter into to a treatment center, it's sort of like when, you know, if you're a hammer, everything looks like a nail. If you're an
Hmm.
addiction doc, everything looks like addiction.
Right.
That's that kind of tendency. I mean, we try to sort this out a little bit better than that. But so, for example, when you enter into a detox center and it's all about addiction, the assumption is made that you go to 12-step meetings and addiction therapy, which is all well and good for individuals with the disease of addiction, but it's a big mystery and unconnected with the real experience of individuals that are benzodiazepine survivors in large part.
Right, right. Well, I had a moderator years ago in my support group, and she actually worked at a rehab, and she was taking Klonopin for sleep. When all of a sudden she said to the main doctor there, she said, I think what I'm taking is worse than what some of these people are coming in here for. And so now she has to start tapering, um, her benzodiazepine. And she ended up writing a book, but I don't know if it ever came out because she had sent me the disc for it. So, yeah, quite interesting as she's learning while she's there that she's on something worse than what some of them were coming in on. So, I think one of my last questions, because we could go on forever because this is so good. When we talked, I had asked, how long does it take for prescribing practices to change when all that's happening right now with the FDA black box warning and all that you have coming out? And I was shocked at your answer. So I'd like you to just talk about that.
Yes. It probably varies broad and wide, but there was an interesting article that came out a while back, and the title of the article, which you can Google and find yourself, the title is intriguing in and of itself. It says, the answer is 17 years. 17 years from the time that something is established as an important element for clinical practice, 17 years until it is really put into practice. And that's really disarming.
It is.
There's other literature and diabetic literature that when things were identified as being best practices, 6 years. We don't know for sure. To generalize otherwise, we don't know. For example, although in a research group with which I'm associated called the Schreiber Research Group, we're taking a look at how long it takes for changing practices when the box warning is introduced. But we're hoping that we can sort out and find better ways, more efficient ways to change practicing. Uh, we're looking to find more effective and better ways and more efficient ways, time wise, for changing practices with regards to benzodiazepines. And we'll keep you posted on the Alliance website as to what we find out.
Good. Thank you so much, Steve. So, everybody, I highly recommend going to benzoreform.org. Wonderful information. And on there will be when the book actually is released. Is that going to be coming soon, Steve?
Don't know the date, but
Okay.
hopefully very soon.
Okay. Excellent. Thank you so much for being on today.
Thank you very much, Geraldine. It's a real pleasure.
Okay. Bye.
Bye.
All right, Garrett, we just finished the interview with Dr. Stephen Wright. And I got to say, he gets everything that we've been through because I mean, obviously you've met a lot of Benzo people now, you've heard them speak, and he understands it fully. It was a great podcast.
It was. I think what I was thinking throughout the interview was, kind of thank God you kind of have somebody who's in the medical field that finally can tell you, I understand what you're going through. Because I think people, we've said this before, but people go through this process alone, and then, you can hear from people that have gone through it. And now with Dr. Wright, you can hear a doctor that will tell you, well, things need to be different. We need to have best practices with this kind of thing.
Right. And the good part is not only does he get it, But now with their benzoreform.org, they're now going to be teaching other medical professionals. So what we've been doing for years, letting patients know that what they're going through is real. Now they're doing it on the other end, which is something that for all these years, has been so needed. And there they are, they're doing it. It's phenomenal.
Yeah, I mean, the difficult thing about that is, and he mentioned it, is the 17 years before it actually becomes part of practice. So it's like, yes, it's there, but how long before this really reaches, the people that need it?
Right. So as I said to him, I was shocked when I asked him that question last week, but I'm hoping today with technology, because that is how long. I remember a doctor who was sick from this when she and I had a conversation. She had said, you're looking at a minimum of 10 years to see a change. But with all the technology today, I was like, hopefully, because I've been doing this for a long time. There were people doing it before me over in the UK. Let's just hope that change starts happening.
Yeah, I mean, the beauty thing of social media and everything today, sometimes things can just explode really quickly. So, benzos have been, nationally publicized as, that people not prescribing them the right way. It just hasn't caught on yet. But at some point, I hope that it works out where it happens quicker than 17 years or 10 years, whatever it is. It's too long.
Right. Anything is too long, but as long as the change happens. When I remember I saw a video years ago that was done in 1980. Now, I didn't get prescribed Ativan until 1988. And I thought, wow, if something had been done, they were doing it over in the UK, it never would have happened to me. But hey, it did, and it's still happening to people. But I think we covered everything. I still had so many more questions, but I didn't want it to go too long for people to I know we tried to keep these shorter so people can just listen over a certain period of time. But, I mean, the book coming out, the Benzo reform, and, the international symposium that happened, and we covered everything the main things, and the FDA warning. Those were the main things I wanted to cover.
Yeah, he was a great guest. And, looking back now with our last interview with Bob Whitaker and now him, and then we have another guest coming soon, I kind of wish that we had called these podcasts something else, like we did like an expert series where it was 1, 2, 3 all in a row, and it's 3 people that are experts in their fields and what you're getting out of their interviews.
Yeah. Well, they're all coming one right after the other, even though we'll do a few more in between, but we'll put those 3. They are all coming one right after the other, and I think we're getting some great information out there for people to. Validation, as we say, is one of the best things, and I think Steve was phenomenal. So, all right, another great podcast.
All right.
All right. Thank you, everybody, for listening.